Hello, my name is Dr. Mustafa, and today we are going to learn how to analyze and report CBC or FBC, which is a full blood count. And this report is something that we will see in our hospitals, in our ward rounds, and OPDs on a very regular basis. So it is important that we know how to approach it. So before diving into that, there are three important things that we must know before interpreting a CBC report. So the first thing is the patient's age and gender, as there are different ranges in different genders and different age groups as well. So we need to make sure we know that. Second is the clinical presentation and the history of the patient. Thirdly, we need to correlate it with the previous labs or the current other investigations as well. That will give us a good picture. So there are basically three components that we will be reading in a CBC. As we know, we have red blood cells, white blood cells, and platelets. In RBCs, we will be looking at hemoglobin, MCV, MCH, RDW, retic count, and we can also talk about hematocrit level. I will talk about them one by one. And in WBCs, we will see at the neutrophils, lymphocytes, eosinophils, and monocytes. And in the platelets, we will look at the bleeding risk, and we will see when the platelets could be a bit higher than the normal range. So that's it about the overview. Now let's talk about our first thing, which is RBCs, that is red blood cells. We will look at its count, and then we will see at the hemoglobin level, which is basically a protein that binds with oxygen. So it has different ranges in different age groups, as we can see, 14 to 18 in male, 12 to 16 in female, and in newborn. It is initially quite high, and then it will fall down over time. So the level can be normal or it can be low. That will indicate that it is anemia. And anemia is basically a finding, and we need to see like what type of anemia it is. So for that, we need to look at the other readings as well. So the next thing that could happen is the level of hemoglobin is high, as we have in polycythemia vera, and in renal tumors, because of the erythropoietin, there could be a high level of hemoglobin. And in congenital heart disease, there is more demand for oxygen, so it can be higher in that as well. Same is the case with the smoker, COPD, in dehydration, and even at people living at higher altitudes, there is more demand for oxygen binding, so it can be a bit high in them as well. So the next thing is the MCV, which is basically mean corpuscular volume, that tell us about the size of the cell. So the normal range is from 80 to 100 femtoliters, and it can be normal, it could be low, or it could be high. If it is normal, then we will call it normocytic, which is the normal cell. And if it is low, this is microcytic, that is small cell. And if it is high, then we call it macrocytic, which is large cell. So normocytic, we see it in acute blood loss. And for the microcytic, the example would be, for example, we have iron deficiency anemia and thalassemia as well. And then in macrocytic, we have B12 deficiency, folate deficiency. It could be because of the liver diseases and the drugs like methotrexate. So these are like few common examples for each type. And the next thing is MCH, which is mean corpuscular hemoglobin. So it will basically tell us the average weight or amount of hemoglobin present in a single RBC. And the normal range would be 27 to 33. So there's another thing that we often see in a CBC report is the MCHC, which is basically a hemoglobin count in total RBCs, which basically is complementing the MCH. So, but these are slightly different. So on the report, the value could be normal, if it could be low, or it could be high. So if it is normal, it is normochromic. For the low, we have hypochromic, and for the high, we have hyperchromic. But this hyperchromic does not exist usually in the physiological state. So that's it about the MCV and MCH. Now let's talk about the next thing, which is reticulocyte. So Reticulocytes are basically immature RBCs that are produced by the bone marrow, and the normal range for them is 0.5 to 2.5%, and they can be high, they can be low or normal as well. If the count is high, it could be in acute blood loss or in hemolytic anemia as well. Why? Because in that kind of state, there is depletion of the red blood cells, or and with that, of course, the hemoglobin and the rest of thing. So there is a more demand for that. So the bone marrow will be producing more cells. So it would be high in that case, and it could be low in the reports in case of aplastic anemia, in chronic illnesses, and in chronic kidney disease. Now, let's talk about RDW, which is reticulocyte distribution width, which will tell us about the sizes of different cells, either they are uniform or variable. So, in that case, it could be in the report, it could be high or it could be normal. And for the normal RDW, we can suspect thalassemia trait, or we can see this kind of image in the initial phase of any acute blood loss as well. So the next thing that could happen is it could be high. So RAW can be high in iron deficiency anemia, and usually we can use RDW as a tool to differentiate between the thalassemia trait and iron deficiency anemia. Now let's combine the few parameters that we just discussed to see like what kind of anemia it is. So as we've discussed, let's say the hemoglobin was low, and to see like what kind of anemia it is, we will look at the MCV, which is mean corpuscular volume, and the MCH, which is mean corpuscular hemoglobin levels. So let's look at it. So the hemoglobin is low and MCV is normal and MCH is also normal. That will make it normocytic, normochromic anemia. And we have discussed the names previously in the lecture. So this could be seen in acute blood loss, or even it could be in early phase of chronic diseases as well. So the next presentation could be the MCV is low and the MCH is also low. It means both are on the microcyte. So that could be named as microcytic hyperchromic anemia. And we can see it iron deficiency and thalassemia. And there are many more. Now we have the third presentation in which the MCV is high and the MCH can be normal or it can be high as well. So that would make it macrocytic normochromic anemia. As we know, it could be in B12 deficiency, folate deficiency as well, and the liver diseases. So that's it about the RBCs. Now move on to the next component, which is WBCs, white blood cells. And the normal range for that is 4,000 to 11,000 cells per microliter. We could also call it TLC, which is total leukocyte count. So on the report, it could be normal, it could be low, and it could be high as well. A normal value does not mean that everything is okay. We definitely need to correlate it clinically. And if the level is low, then it means it's leukopenia. If it is high, then it is leukocytosis. The both condition can happen in sepsis and infection, and they can basically sometimes indicate the prognosis of a disease. So this is not enough. We need to look at the further differential leukocyte counts to see what this rise is indicating. So if we look at the neutrophils, if they are high, that mostly indicate an acute phase of infection, that some acute problem is going on. It could be high in case of steroids intake and in the stress situation as well. The next thing is the lymphocytes. So lymphocytes can be high in viral illnesses or subacute or even in chronic illnesses as well. The third component is the eosinophils. It could be high in allergic state. For example, we have in asthma, the eosinophil levels are a bit high. It could be more in parasitic infection. And the monocyte level could be high in the chronic infection as well, or it could be high in the recovery phases of inflammation as well. So it's important for us to know like what type of white blood cell is high, as it will help us in diagnosis. So let's move on to the third part, which is platelets. So like any value, it could be normal, it could be low, or it could be high. So if it is normal, then it's good. But if it is low, then it might indicate that there is a bleeding risk, and it can be high in reactive phases, which means that it is high in response to a problem that is going on in the body that is not directly originated from the bloodline or the blood cells, but it is a response to an ongoing infection. So about the bleeding risk, it's important to know that if it is less than 20,000, then it is a risk for spontaneous bleed. And if it is less than 50,000, then there is a bleeding risk high if we do any procedures. So we need to make sure that we know the clotting profile and the platelet level of the patients. So just to take an overview, the platelets can be high in case of sepsis. Uh, they could be a rise in their number in the initial phase. It could be high in the patients who underwent splenectomy because spleen is needed to break down the unnecessary platelet level. So if it is not there to do that, there would be a sudden rise in the platelet level initially. And it would be high in the early phases of infections as well. And let's say when it would be low, so it can be low in hemodilution, which means, for example, in a post-op patient, if the fluid is given aggressively, it can lead to hemodilution. So there is like low, it can appear to have a low level of platelet. And other than that, there could be DIC, could be in dengue fever as well. So to see the platelets, we need to look for the CRP, PT, APTT, INR, LFTs, and the iron profile as well to take a good picture like what exactly is going on. So that was it about the CBC. And just having a look at it, we have discussed the RBCs, WBCs, and the platelet component. And these are the major basic diagnoses that we can make from it, but there are a lot many more. If you have any question, just let me know. I will try to answer it with the best of my knowledge. And this is it for today. Thank you for watching.